I'd like to formally welcome Pete Setabutr here to our visiting professor rounds at the Flaum Eye Institute. Wish we could do it in person, but maybe we'll do it again sometime soon, Pete. He's a professor of ophthalmology, director of ocular plastic and reconstructive surgery, as well as the director of the Millennium Park Eye Center and vice chair for global ophthalmology at Illinois Eye and Ear Infirmary. How do you find time to operate? So he received his bachelor's, actually a BBA at the University of Texas, Austin in '98, and then a doctor of medicine at the University of Texas Health Science at Houston in 2002. Did his residency at the University of Texas, Houston, 2003 to 6, and then fellowship with Alan Putterman at University of Illinois at Chicago, where he has remained since. He's active in teaching and multiple academic endeavors. He's received the Golden Apple Fellow Teaching Award at the University of Illinois, the President's Volunteer Service Award, the President's Council on Service and Civic Participation, Best Doctors in America, and a Castle Connolly Top Doctor. Locally, regionally, and national outreach he's been involved in, as well as teaching and national service. He's chaired the American Society of Ophthalmic Plastic and Reconstructive Surgery Journal Committee. He's reviewed for the American Academy of Ophthalmology for their annual meeting program. He's reviewed for the American Society of Ophthalmic Plastic and Reconstructive Surgery at their annual fall meeting committee. He's been on the writing committee for the basic and clinical science course. He's a member of the American Society of Ophthalmic Plastic Reconstructive Education Committee, representative for the clinical practice guideline on post-Mohs reconstructive surgery. We were glad to hear your wisdom on that today. He's a member of the ASOPR's Industry Relations Committee, a member of the ASOPR's Continuing Medical Education Pilot Program Committee, and a Global One Advisory Board member for the American Academy of Ophthalmology. He's had 6 visiting professors or name lecture talks in a short career already and published over 50 publications. He has a strong interest in global health, specifically in Southeast Asia. His work in this region has helped build a sustainable training and educational program in the field of oculoplastics and orbital surgery. He lectures extensively in not only this region, but around the world with strong interest in clinical research that focuses on maximizing surgical outcomes. We're pleased to welcome you here today, Pete, and to present your 2 talks, the droopy eyelid consult and complications of ocular plastic surgery. Welcome, the floor is yours.
Thank you so much. Thank you for having me. I'm excited to be here. I was kind of hoping that I would get a visit, and maybe when the world gets a little bit better and safer, that we can make that happen.
That'd be great.
Let me see, share screen. It's funny, doing this for a year, I still feel very uneasy about making it happen, like to make sure that my slides get on a screen. Anyway, they're up.
Perfect.
Okay, good. So, I have 2 talks, and I tried to make them somewhat related. This is kind of one that I always find that, no matter your specialty is of interest, as well as the second one, talking about complications. So, let's see. There we go. I have no financial disclosures, and, patients don't come to my clinic or anyone's clinic for that matter and really tell you what they have, and when it comes to the droopy eyelid, they come and say a variety of things. Sometimes they'll tell you what they need. I had a patient tell me this morning, they came in for a blepharoplasty. Sometimes they come in and they say, I have a drooping, my eyes are drooping. I've got bags on my lids. I've got extra skin on my eyelids. I've got a lazy eye. What's our job? Our job is to figure out what you have. Our job is to figure out how we can treat you. So it's on us to figure out what they need. So I show this picture, and I'm not showing this picture to bag on anyone. This is something I took out of an airline magazine when I was flying for one of these lectures, and it was perfect because I just put it in my talk. So this is a plastic surgeon showing some of his pre-op and post-op photos in an ad. So paid good money to put an ad, and obviously the patient's super happy, which is the number one most important thing, is that the patient's happy. But for us to be a little bit more critical, we can see that not everything was done. So preoperatively, he has ptosis, right? He has ptosis, brow ptosis, and dermatochalasis. My arrows have moved, but you can see them all. Well, postoperatively, he still has ptosis and brow ptosis. So basically, he had a blepharoplasty and is happy that the skin looks a little bit tighter, but look at his eyelids. He's got an MRD of pretty close to 0. So functionally, this gentleman's probably missing some of his visual field. So sometimes it's obvious, right? Like this patient has ptosis, his lids are drooped. This patient has brow ptosis. The brows are hanging so low that the eyebrow, right, the temporal portion of the eyebrow is actually lower than the inferior limbus, right? So this is obvious brow ptosis. And then this is dermatochalasis. This is, this woman came to me saying she has extra skin on her lid. Does she really have extra skin? No, but she has what's perceived as extra skin or hooding of the skin, if you will. So, but more common than not, a patient has all 3 of these or some combination thereof of brow ptosis, ptosis, and dermatochalasis. And our job is to figure out A, what they have, B, what can be done about it, and C, what the patient's willing to tolerate. Because sometimes some of these procedures are a little bit more invasive than others. So it's important to see what the patient's willing to have done. So we'll do a quick review of each of these topics and then talk about how we can repair them. So ptosis, what do we know? It can happen at any age, right? It can happen at any race. And typically we like to classify these based upon if they're congenital or acquired, and then we further categorize them into different categories based upon the different causes. So we looked at our numbers here at the infirmary a few years back, and this is kind of the breakdown of the diagnosis of ptosis. And I highlight here that just under 6% of these cases were neurogenic. And I always stress this to the trainees here that if 100 people come, close to 6 of them are going to have a neurogenic cause of ptosis. So that's something important to remember. And I have a few cases to demonstrate that. So this is a young woman who I think is in her early 20s, and she's been bothered by her left upper lid that's been droopy for her whole life. But if you look closely, what does she have? She has a small pupil. She has miosis. She reports a history of sweating on one side when she works out. So she has anhidrosis. She has the obvious ptosis, and she has an elevated lower lid. And she has iris heterochromia if you look even closer. So what does she have? She has the congenital Horner syndrome. This is a patient. This is an interesting series of patients. So the patient on the left of your screen, he came into my clinic. The resident saw the patient, came out and presented this case of, this patient, has a droopy eyelid, can barely keep them open, had poor levator function. We went in, we talked to him, and, after talking to this guy, he explained how he had trouble swallowing and getting upstairs and all these things. We sent him up for genetics for analysis, and he has oculopharyngeal dystrophy. So if that wasn't cool enough, 2 years later, the woman on the bottom right comes into my clinic and gives a similar story, but doesn't say anything about, difficulty swallowing or weakness elsewhere. 2 years later, it's a different resident who's training with us. I walk into the room, and I don't know what reminded me of these people, what this woman reminded me of the previous man, but I immediately impressed my trainee by saying this woman has oculopharyngeal dystrophy and started talking about all these vague symptoms of swallowing and weakness. And sure enough, they're brother and sister. And then about a year later, the gentleman on the right on upper came in. He's the brother. And then I don't have the photograph, but we actually have another brother. We've been trying to get a hold of the whole family. So this is an interesting case, again, of a patient who has, yes, has ptosis. And yes, that's what brought them in, but definitely has many other medical needs. This is Myasthenia Gravis with a positive ice pack test. Again, this is a patient where immediate surgical intervention probably isn't the best course of action. But why do we even care about ptosis, truthfully? And the reason we care is because it affects the patient's quality of life. What we know is it affects their ability to perform manual labor, it affects their visual field, it can affect their ability to read, to exercise, and then of course, appearance and self-image are definitely part of that. Dermatochalasis, right? This is that hooding or that redundancy of eyelid skin. Patients typically present with heaviness around the eyes, a brow ache, lashes in the visual axis, and they can also have a reduction in their visual field. There's an association with increased age, eyelid ptosis, attenuation of the skin fold. Lower eyelid dermatochalasis is very similar in that they can have fat prolapsing and extra skin. This is typically considered cosmetic. So this is the woman from the previous photo. So obviously she's significantly younger. So this isn't necessarily associated with increased aging, but she still has that same appearance of redundant skin, when the truth is she has a lower crease, which is similar to a good portion of Asian patients, giving her this appearance of dermatochalasis, of extra skin. And then you can have eyebrow ptosis, where the brow is low and descending, typically more common in females, and it can result in hooding that gives you a lot of the same symptoms as dermatochalasis. And it's important to differentiate between the two, and to identify that if the patient has any underlying brow ptosis, because quite often these patients don't know this. They come in and they say, I have this extra skin. Could you please remove it for me? If you only treat their dermatochalasis often, you just won't make them better. You may make them slightly worse. So we'll go over some of these treatment options here in a bit. So no matter what you have, this is kind of my exam sheet. This is what you need to go over with the patient. So you need a good history, right? Duration, variability, trauma, surgery, contact lens wear has been shown to be associated with ptosis, dry eye, thyroid eye disease, because maybe they're not ptotic, but they're retracted. Something we heard earlier in the thyroid eye disease talk. They have family history or other neurological symptoms. And on exam, vision, motility, pupils are very important. And these are the eyelid measurements that I seem to focus on, and we'll kind of go over those in a bit. And if you have some level of suspicion, you can do other tests like the ice pack test, apelclonidine testing, or get scans. And then you need to treat them with either surgery or medical therapy. And nowadays there are some medical therapy options for this. So my most important measurements are the palpebral fissure, MRD, margin of crease distance, margin of fold distance, and levator function. And so here on this diagram, the palpebral fissure is the opening of the eyelids. The margin of reflex distance is that distance from the light reflex to the upper eyelid. This is the margin of fold distance from the upper eyelid to the eyelid to that fold of skin. And then the skin, and if their eye was closed or looking down, you can see the crease. Just a quick reason why we care about that margin to fold distance. It may sound kind of arbitrary, but the reason is patients often associate that distance with aging, right? So if you have a ptotic patient, right, if the lid is low and you lift it, that margin of fold distance gets lower. And so this is something the patient needs to understand, that distance is going to get smaller. And if they don't like it, they're going to probably need a blepharoplasty to go with it, or else this patient may be, though happier that their eyes are open, they may be upset that cosmetically they have what I guess society has deemed a more aged appearance. Levator function, this is the most important measurement, and this kind of helps us determine what type of surgery we're going to do if it's ptosis. That's from down gaze to up gaze, the total amount of excursion. And phenylephrine testing, we place a drop of phenylephrine into the superior fornix to measure the strength of Mueller's muscle and determine if they can have a Muellerectomy. And so this is my algorithm. And there's one alteration that I recently made, but so basically if they have poor levator function, they're getting a frontalis sling. And right now we're actually doing frontalis flaps versus slings and finding good results with those. If they have good or moderate levator function, they get a phenylephrine test. Positive response, everybody here gets a Muellerectomy. Negative response, they get an external levator advancement. This isn't what is been taught in the basic science course series, but here at this institution, where I've learned from Dr. Putterman, Muellerectomy is basically the surgery of choice. So here you can go an internal approach for your Muellerectomy and an external approach for the external levator advancement. Just a quick look at the anatomy to remind yourself, if you're targeting Mueller's muscle, the reason is Mueller's muscle is attached to the superior border of the tarsus inferiorly, but superiorly it's attached to the underbelly of the levator complex. So right out of fellowship, I was always asked, why does the Muellerectomy work? And there've been, I don't know, many different attempts to address this. I'm not saying I have the answer, but I tried to figure it out myself. So we perform Muellerectomies on cadavers. We exonerated the orbits and we fixed them. And what we found is, yes, conjunctiva is resected. Yes, Mueller's muscle is resected. That we knew. What we didn't know, but maybe some of us thought, was that levator was actually advanced. And the reason is because from an anatomical standpoint, the Mueller's muscle is actually attached to the underbelly of the levator. And so you're advancing levator as well. And it folds over and scars in place. So that's what's demonstrated here, that the resection itself right here is advancing advancing levator muscle. So it's actually a levator advancement, is what a Muellerectomy is. What we've seen over the years is, a preference to perform this procedure. We did a survey of ASOPR members. This was a good while ago, but so what was this, 2011? So 10 years ago, 3/4 of people perform some type of internal levator advancement procedure, and more than 50%, 61% prefer to do it. My guess is that as more and more trainees, fellows have trained at institutions that kind of taught this, that number is probably a lot higher. So the advantages: it's reliable, it's predictable, it's more efficient, it's better contour and shape, and there's no skin incision. I often tell patients that, this is the procedure that has very little to do with me. This has to do with an algorithm that's been tested for 30, 40 years based upon thousands and thousands of cases, where we determine how much to resect. And that's the next question: how much do you resect? So if you do a quick lit search, you'll find, I don't know, a host of different algorithms. And here are kind of like the 5 more popular ones that people discuss. The original one by Dr. Putterman in the late 70s is that he does an 8.25 millimeter resection for a phenylephrine response. I've always thought it was difficult to measure that quarter when I was his fellow. So we looked at our data, and what we basically found is that minimal adjustments within that range of 8 to 10 doesn't really affect your result. And so for me, I do an 8 millimeter resection, and I believe that will mimic the phenylephrine response regardless of what the level of ptosis is. And so historically speaking, the teaching was Muellerectomies were only reserved for small or mild amount of ptosis, less than 2 millimeters. If you actually look in your BCSC for the last 2 years, I think that's been updated to say that Muellerectomies can perform for all types of ptosis, severe to mild levels of ptosis. And that's what I believe. I believe that it depends on your response to phenylephrine. And so here's a case where the woman has a right upper eyelid ptosis. This is 5 minutes after installation of phenylephrine, and then this is her post-op. And you can see that the phenylephrine and the post-op look very similar. So for me, from a clinical standpoint, this is a good option because I can show the patient what I expect their result to be. They can look, and nowadays everybody has a cell phone that has a selfie function, and quite often these patients take a picture of themselves and they decide if they like what they see or they don't. And in addition to that, they can see that distance I was talking about, this margin of fold distance that's a lot less, if they can accept that. And if they can't, if there's anything else that we can do about it. Just some quick points about the procedure itself. I have to thank all my colleagues who've contributed kind of their photos for these different ways of how they do it. So anesthesia, you can do a block, which Dr. Putterman still does. My friend Bobby Korn does a subcutaneous injection. Others do transconjunctival injection, subconjunctival injections. They all work. Me personally, I do a little bit under the skin and a little bit under the conjunctiva. You flip the lid, you mark. I mark about 4 millimeters. You can mark it with a cautery. You can use a suture, which is what I use, or you can use a pen. We then elevate that amount of tissue. We place the clamp. Remember, if you're marking 4 millimeters, the resection's 8 because it's tented up. You place the clamp, make sure it's perpendicular, make sure that you're consistent to the center of and that you're centered to the tarsus, and that you're right at the tarsus. And then you pass a suture. I use a 6/0 plain gut suture. I pass about 1 millimeter away from the clamp. Again, for me, I think whatever you do, as long as you do it consistently every time, you can get predictable results. You bevel the blade up when you cut so that you don't cut the suture. In the next talk, we'll talk about what happens when you do. and then you close, and some people run it back, some people externalize the knot. I run it back still. There are people who externalize and close it in a blepharoplasty incision. Some people just externalize and has a little dimple there that eventually will go away when the suture dissolves. There are a couple different clamps out there. The one on the left is the same clamp that Dr. Putterman helped devise in the late 70s, and the one on the right was developed at Bascom Palmer by Dr. Erickson and Wendy Lee. We have them both here. Theoretically, it's a little bit easier to use the right one. I think it's the same. I think the results maybe are a little the same. I would say the right one maybe makes it easier to get an overcorrection. So word of caution, here it is. This is the actual photo from Dr. Wendy Lee using her clamp. Just some pre-ops and post-ops, because what's a plastic surgery talk without pre-ops and post-ops? This is right upper eyelid ptosis and a straight 8mm resection. You can see there's a good lift, great contour. It's matching. Again, please note the decrease in that margin of fold distance. It matches the other side, so the patient was willing to accept it. This is a case of severe ptosis, right? So, you know, a handful of years ago, I think people would say you shouldn't perform mulerectomy for this patient, but you can see she's got a good lift, good contour, good shape. Let's see. This is from the side view, so you can see that change in the margin of fold distance. Here's, you know, our paper talking about severe ptosis. Gentleman has like a -3 on the left, has ptosis and a better haircut, so he looks better in his post-op photo. And he has, you know, this is 5-6 millimeters of lift with the mulerectomy. Same thing here. We do perform it in children. The key to remember to do this in kids, they have to have good levator function and a positive response to phenylephrine. I will admit that it is not as predictable as it is in adults, but in certain cases, it's a good tool to have. The left upper photo is the patient's pre-op. The photo on the bottom is for post-phenylephrine. And then you can see we get a very good result that matches the phenylephrine response on the right. The one drawback here is because you don't make a skin incision, you can't create a crease. So she doesn't have matching creases. She has matching eyelids, but not matching creases. But it's, you know, shorter anesthesia time for a kid. There's good contour. So after discussion with the parents, this is what they chose. You know, here we have colleagues who do all kind of severe cases in terms of corneal disease, and MMCR can be done. This was a paper talking about doing mulerectomies on patients who've had corneal transplants or filtering blebs. I've done them on patients with K-Pro. This is a patient who has a right-sided K-Pro. I think I presented this at the ASOPers meeting a handful of years ago. And the comment, which I don't disagree with, the comment is, wow, why would you take a risk of doing this on a patient who is such a high risk for having failure of their K-Pro? And the only thing I could say was these patients go through so much to get this, right? So much, and they have to deal with so much to maintain their K-Pro. If they really can't see out of it, what was the point of them having it? So we'll lift it. We intentionally just try to go above the optic just so that they can see out of the telescope. Quick discussion about external levator advancement. Again, we do them here. It's not my procedure of choice, but we do them. I think the most important step is preoperatively we mark where I want to put the sutures. More often than not, if I place the sutures at the medial edge of the pupil and the lateral limbus, that requires me not to adjust it too much. Quick skin incision, dissection down, removing the orbicularis on top of the tarsus, and then I place the 2 sutures at those points that I marked preoperatively, close it up. I show this photo because you can see where I made those marks preoperatively of medial pupil lateral limbus, and right after surgery, this is a pretty good result. This is a patient with severe ptosis, unresponsive to phenylephrine, had external levator advancement, now is nice and open. Same thing here. Just to show that I don't discriminate in terms of patients who have keratoprosthesis. This is a patient who had an external levator advancement to open her eyelids for a K-Pro. Now, in my opinion, she's open a little bit too much here. And my cornea colleagues would probably agree. The patient actually did not want to have it dropped, and she's been stable since. My cornea colleagues actually have all these patients in contact lenses, so that's helped maintain some moisture for her. Blepharoplasty. This is excision of skin, muscle, fat, sometimes a combination of all of them. It can be done for cosmetic reasons as well as for functional reasons. For me, I tend to set the creases at 7 to 8 millimeters in men, a little bit higher in women. And the number one rule is that we try to leave 20 millimeters of skin because that minimizes the risk of lag ophthalmos, which can be very challenging and painful to deal with in the postoperative period. In order to minimize a web at the medial canthus, instead of doing this traditional kind of sharp angle immediately, I kind of change that and I take a 45-degree angle. And that has shown to decrease web prevention. This was published by Phil Custer out of WashU probably about a decade ago. This is what we do. We mark the crease. We do a skin pinch test to determine how much we resect, remove skin, remove fat if needed, and close. And pre-op, post-op. So this is very subtle because that margin of fold distance, though higher, isn't significantly higher, but the lids just look a little bit more clean and a little bit more touched up. Same thing here, just opening up, giving a little bit more platform show. This is a gentleman who had a blepharoplasty, and you can see his margin of fold distance is minus, right? The lid is hanging on the lashes. And so we excised a little bit of skin and he has a little, it's no longer hanging over. But truthfully, this gentleman has brow ptosis. He did not want a brow lift because he did not have the greatest hairline, so we couldn't do anything endoscopically. Or I don't like to do them endoscopically when they don't have a great hairline because I can't hide the scars. He didn't want to direct either. He was kind of content, and so we left him like this. This is a woman who, again, just wanted a blepharoplasty just to improve her appearance a little bit. This is actually one of Dr. Putterman's photos from way before. And this gentleman had ptosis, brow ptosis, and dermatochalasis and opted just to have the blepharoplasty and the muleirectomy. And you can see the brows are still way too low. The lateral edge of the brow is still lower than at least the pupil. But again, this has to do with talking to the patient. He didn't want anything more. He didn't want anything bigger. He just wanted to open his eyes a little bit more. This is a photograph of one of the cases that we did, I think, in Thailand. Yeah. And so in Asia, it's a little bit different, right? Asian blepharoplasty is important. It's really important to discuss the patient with what they want. Some patients who come in, they want skin no longer hanging over a hooding, but they want to maintain kind of that ethnic typical Asian eyelid because you don't want to change their overall appearance. Whereas this patient, I asked her how much she wanted. She wanted about 3 millimeters of, we use a creaser to show, she wanted about 3 millimeters of platform show. And this is what she got. She wanted a kind of slightly westernized look. Whereas this woman was very, very adamant. She's like, I just don't want it hooding over so I can see a little bit better, but I still want kind of that typical Asian appearance. Brow lifting. So the considerations for brow lifting, how low are the brows and what are the expectations? Because you got to make sure that those expectations can be met. For me, I think a hairline is important. I know some surgeons don't really care and they'll do different lifts despite the hairline, but I think it's always easier to hide the incisions, how thick is the brow, and is the patient willing to accept the scar and where they're willing to accept the scar? And is the patient willing to accept a prolonged recovery? And what other surgeries they're willing to have. Because quite often patients want a brow surgery, a brow lift, but then when they find out exactly what it is and what it entails, they decide they don't. So we're going to go all the way from the least invasive to the most invasive. The least invasive is a Botox brow lift. It does work. It doesn't last forever, and it is a modest lift. There's no incisions, right? There's low side effect profile. It does get quite expensive because they have to come back every couple of months to do it. But for this patient, right, it's a subtle lift and she's happy. She's a little bit higher. You can kind of customize it to get things to be as symmetric as possible. A direct brow lift. This is the best bang for your buck in terms of lifting your brow. It doesn't lift your forehead, but it does lift your brow. I'm not convinced that this patient could have a successful endoscopic or pre-tracheal brow lift, where you would get his eyelids off of his eyelashes, where as open as he is here. For this type of patient, I tell them it's a direct is the only thing that's going to last and give you good function. So it's less likely to drop. You do have a visible scar. There are things you can do about those scars to make them better over time, like how you place the sutures, and post-operatively, you can do things like dermabrasion or laser resurfacing to improve that. But it does not address the forehead. So this is a patient who came to see me after he had a direct, and you can see this scar. And this is the patient, what I show patients when they ask about how bad can the scar be. Obviously, it's not going to be this bad, but I like to show what the worst case scenario is. So this patient has a scar that's way above the brow, and it's very noticeable. This is a patient who came in, he had brow ptosis, ptosis, and blepharoplasty. We did all three and got him up. He's still undercorrected. I would say he is in his brow ptosis, but he doesn't want anything more than that. Brow Pexys, a lot of people don't believe in these. I find that they're very helpful for those patients who just want to be slightly elevated. There's no scar other than the bleph, and we just basically anchor the temporal brow to the periosteum. I do it about a centimeter above the orbital rim. You do get a little skin dimpling because basically you're lifting the brow, but you're not lifting the forehead. And so where that area where the two meet, you get a little skin dimple. This is a patient who wanted a blepharoplasty and deferred a pre-tracheal brow lift, and he just wanted a little brow pexy. So his brows are up, his skin fold is improved, and he's happy. But if you look closely, there is a little bit of a skin dimple in this area. Pre-tracheal forehead lifts. This is my cosmetic lift of choice more than an endoscopic. I find it easier to do with a little bit less stress. And even though none of these hold, it holds a little bit longer, at least in my hands, than an endoscopic lift. It does lower the hairline. They are going to have some numbness in their forehead. It does require a little more surgery. I dissect in the subcutaneous plane and basically lift the whole forehead and suture it right behind the hairline. Coronal forehead lifts. I don't really do these, but it's very similar. You can lift the forehead. Some people believe that they're less likely to drop. You can hide the scar, but sometimes you do get hair loss, and that it makes it really noticeable. Endoscopic forehead lifts. I think these are only good in young people who are looking for a modest lift. It's less invasive. I agree. It does lower the hairline a little bit. You'll get a little bit of scalp dimpling, and you do have risk of injuring both the facial and the supraoral nerve. So here is a patient who came in. She actually came in asking for an endoscopic brow lift. So we did surgery and elevated her brows, but I like to show this photo because this is a lot more than just doing a small blepharoplasty. At 1 week, even at 2 weeks, she has significant swelling and ecchymosis. This isn't something where she's kind of ready to get back out to her normal life. Even at 2 weeks, I tell these patients that they're going to have a full month of recovery. This is her pre-op and her post-op. You can see she's more open. Her brows are lifted, and she was happy. Same thing here. From this view, you can see that her brows are elevated, slightly peaked, and she has a good margin of fold distance. So this is kind of a cool thing that we've been doing. These are eyebrow lifts for patients with facial paralysis. This patient has facial paralysis and her brows are low. And so what do? We started doing the power brow, where we basically use a titanium plate and attach it to the skull, and we basically hang the brow. This was first published by Tessa Hadlock at not at Mass Eye and Ear, but at Harvard. She's part of the facial plastic surgery department there. And so we use a 5-ring implant, and then I use a Keef needle to kind of string a 2-0 nylon suture, and then we elevate the brows. So in this photo, this is a great result. However, you can see that this peaking of her brow, I can't really do much about that because this is a tattooed brow, but her natural brow is okay. It's just that this tattoo now is peaked because she had the tattoo drawn after she had the palsy. Same thing for this gentleman. Good lift. They last, it stays, it holds. You can get a great lift on a patient who basically can't lift their brow. So I think this is a great option for patients who have facial palsy. All right, so that's the end of this talk. And then next, let's talk about complications, and maybe I can take questions about all of this at the end. Does that work for you guys?
That's great. Thank you.
Great, Pete. Thanks.
I know it's a Friday. Somebody told me a long time ago, the best thing you can do is finish a talk early. So complications of oculoplastic surgery. The thing is, like, we all attend conferences and listen to people like me come give a talk, and we all show our techniques and things that work. But the truth is if you do enough surgery, you're going to have a complication. And you're going to see other people's complications. Patients are going to come in for a second opinion. Your partners are going to refer you things that are complications. So I think it's important to learn what they are, learn how to minimize the risk, and then maybe how to treat some of these things. So typically I give this talk and it has all kind of complications, but to fit into the time constraint and to make it kind of relatable to my previous talk, I'm going to kind of limit it to eyelid and facial procedures. So blepharoplasty complications. So this is the list. It's pretty long and it's extensive, right? And things that are kind of mild. I'm sorry?
I'm not seeing your screen.
Oh, okay. Let's see. Share screen.
Now we got it.
Now we got it. Okay. So this is blepharoplasty complications. A whole list of things. Some of them are mild, and some of them can be pretty severe. Things like double vision, loss of vision, infection. But I think the most common one is the bottom one, bottom right, dissatisfied patient. And it's all about it setting expectations. So this is something really mild. You have a wound dehiscence, and this was a late wound dehiscence, about not even 2 weeks after surgery, the patient came in. So I don't really think this is, the suture broke or trauma, so we thought this was maybe like a low-grade infection. We treated her with antibiotics and she got better. At first you're always tempted to, like, I'll just open it up and put some sutures and it'll be better. I think at this point, what's done is done. The scar, is there a scar? Yes. Is it bad? Depends on how you look at it. We opted not to do anything, and she got better with time. This is a patient who has a hypertrophic scar. Treated her with steroid cream and basically a lot of reassurance, and again, got better with time, but something you have to kind of take the time to talk to a patient. Well, this is a little bit more hard to deal with. So I don't have a photo of one of these, but this is from a paper by Don Kakawa, where you have asymmetric eyelid creases and folds. And this is a pain to fix. This is next to impossible to fix. But why does this happen? Because uneven markings of the crease. How can you prevent it? I think you have to be thorough and meticulous when you measure the crease, especially in young patients. I use a caliper and I measure at multiple points and I measure it again and again, because sometimes you don't want to measure from one side, from the eyelashes, and from the other side, from the lid margin, from the other side, maybe the patient has a tattoo. Just be very consistent with how you make these measurements. And if you end up with this, what can you do? You can do a crease revision with fixation to the levator. So you you make an opening in the lid where you think you want the crease to be, and you try to create it by creating either a scar tissue or you fixate it to some deeper tissue. But at least in my experience, I don't find this as predictable. So unrecognized brow ptosis. I talked about this in the previous talk. This is a complication. Patient came in, wanted, eyes to be a little bit more open, had surgery, and looks the same. And that's because the brow ptosis wasn't addressed, right? So they had surgery to basically look the same. And so you're going to have a dissatisfied patient. How about something more severe, globe perforation? Like, this is real. It happens. Luckily, I haven't had it happen, but it does happen. So I think it's important to discuss. If you look in the literature, there's tons of reports of basically open globes caused during eyelid surgery. So, things to think about. You want to prime the needle, direct the needle away from the globe, inject slowly, and pull the lid away from the globe when you inject. This was something that was referred, one of my cornea colleagues saw. There was an open globe injury during a blepharoplasty from the local anesthetic. I always use a corneal shield. I don't see why anybody wouldn't. It's just going to protect the eye and protect you and give you a little bit more comfort. Intraoperative fire, it's real. Like, you would think it's rare, but there are about 100 cases a year in the United States, and a third of them are in the head and neck area. So some things to think about: how can you minimize your risk? Turn off the oxygen during cautery. Make sure that the nasal cannula isn't under the drape, creating this pocket of oxygen that's ready to ignite, and be aware of some of the surrounding tissues such as gauze and drape. I've actually been in an operating room where the room next door had a fire. So these things do happen. Dry eye sounds like it's nothing, but about a 25%, a little bit over 25% of blepharoplasty cases, the patients have dry eye symptoms, and they're often irritated and bothered. And most of the time this goes away again, but this is one of those things that it's important to talk to the patients about. Risk: pre-existing dry eye, eyelid laxity, pre-existing a lag or scleral show, or patients who are on hormone therapy. So I talk to patients about this all the time because, sometimes I've had patients where you've done it and they just, again, they feel irritated because they came in for a cosmetic procedure and now are leaving with a medical problem. So it's important to discuss this with your patients. And then I think this is what is the number one consult that I get from someone who's had cosmetic surgery. They get, after aggressive blepharoplasty, they get cicatricial ectropion like this woman has, lag ophthalmos like this woman has, eyelid retraction like she has, and corneal exposure, right? So this person went in, and if you look closely, not only did she have too much skin resected, the incision is way too low. This, we like a nice subciliary incision. This is 6-7 millimeters too low. My guess is that she didn't get any lateral canthal support and now has a medical problem. Well, beyond that, don't forget this patient went in for a cosmetic procedure, now has a medical problem that could cause her to have severe ocular complications. Oh, and the only way to really fix this is to maybe give her something that isn't too aesthetically pleasing, such as a skin graft or a mid facelift. It's really, that's something hard for her to follow. Hard to accept. You have to use things to remember, judicious removal of skin. Talk to the patients about their expectations, that you're doing eyelid contouring versus large skin excisions. You can opt for skin treatments instead. Here, I think I've seen this so much that when I actually perform my own cosmetic upper and lower lid blepharoplasties, I'm way more conservative, and I'll tell patients that up front, I'm going to leave you with a little bit of extra because you need a little extra to make sure you can close your eyes, because the last thing you want is to have a skin graft placed or something because you can't close your eyes. It happens all the time. I just saw a patient who went and flew all the way to California to find, one of these social media Instagram surgeons, now has lag ophthalmos and severe cicatricial ectropion that we have to fix. So again, went through all this trouble, paid all this money to have a cosmetic surgery, and now has a real medical problem. If it's mild, little topical steroid, massage, I find out hand holding, some time in the chair and encourage massage can really do a lot. If it's mild, we've seen it improve significantly, and that's great. However, if it's severe, you can open the wound, let it granulate in, or just jump in and do something to correct this surgically. Things you can do are skin grafting or tarsal suspension or a mid facelift to address anterior lamellar deficiency, the deficiency of too much skin or muscle being excised. If there's middle lamella, you can stretch or kind of release the adhesions. And posterior lamellar deficiency, that's even tougher because you have to replace the posterior lamella. As I've mentioned a couple times today, my preference is free tarsal graft. Other people use hard palate or ear cartilage. All those work. Patients typically don't like them, but they work. This is a case of a patient who went and had cosmetic four-lid blepharoplasty. And you can see he has cicatricial ectropion. He has a shortened interlamella. You know, I talked to him about all these different options. He was adamant. He did not want a skin graft, and I probably don't really blame him. So he's a little bit older and had a little bit of mid-face descent. So we did a kind of a cheek lift, mid-face lift, and then I did a little skin flap to augment that from the upper skin. And this is him. You can, if you look closely, you can see my scar. There's a little bit there, and he's still a little bit retracted. There's a little bit of scleral show, but he is no longer ectropic. He's no longer constantly tearing. He doesn't have lag. He's comfortable and he's fine. And then this is when things get a little bit scary, right? So I got this case from my neuro-ophthalmology colleague. He was referred a 72-year-old female who had 4-lid blepharoplasty at an outside hospital. Called the doctor that night and said, I'm having pain and pressure. He said it was normal, don't worry about it. Called the next day saying it's getting worse. He had the patient come in, vision was down to 2400. There was a APD, swelling, proptosis. So this is a retrobulbar hemorrhage, was taken to the operating room and immediately drained. And then my partner saw her at UIC, and the patient basically already had a compressive optic neuropathy. And, you know, initially the exam wasn't that bad. The nerves looked okay. Maybe some pre-existing glaucoma for the glaucoma people in the room. But in time had permanent visual field loss, and OCT had thinning of the nerve. And so again, the patient went in for cosmetic surgery and now has compressive optic neuropathy with visual field loss. Like, that's just not a good thing to have. So things to think about in terms of hemorrhage, peribulbar hemorrhage, I have this in caps, you need to rule out retrobulbar hemorrhage. And if you're not sure, you need to see the patient. Conservative treatment rarely needs drainage, cool compresses and reassurance work. But if it's an expanding hematoma, they require to be drained, explored, and have all the bleeding stopped. Orbital hemorrhage is rare, like 1 in 2,000 cases, and permanent vision loss is even more rare, but it does occur. And the thing is, most of the time it's going to happen within the first 24 hours. And the most common symptom is pain and pressure, which is shown on this diagram. So I think if you feel those phone calls, it's something to not ignore if the patient's having pain and pressure. And I know, like, they had surgery, every patient has pain and pressure. I just think it's important to keep that in the back of your mind, that they could be having something that could give them permanent vision loss. Risk factors, systemic disease such as hypertension, or patients who are on certain medications such as aspirin. Like, these are all things that you need to take into consideration while they have an increased risk of having a complication from bleeding. What you can do about it is take note of these, discuss with the patient, discuss with their primary care physician or their cardiologist if some of these can be stopped. Now patients are on all kinds of supplements that aren't necessarily in the chart, so it's important to go over these with the patients. Some of the supplements I have listed here can cause increased risk for bleeding. Intraoperatively, we're all in a hurry, but it's important to control hemostasis. And I always recommend avoid excessive traction or pulling of the fat when performing lower lid blepharoplasty. Postoperatively, I have them elevate their head. Everybody gets an ice pack, and if they're nauseous, I give them some medication to help with that. Once it's happened, they need an exam. They need imaging and medical management. Glaucoma meds or topical or systemic can help lower the pressure. Systemic steroids can help, right? But once you start getting into that severe range and you're starting having compressive optic neuropathy, you got to take them to the OR. I don't care if this is cosmetic surgery. This is no longer about their cosmesis. You have to explore, you have to evacuate, you have to stop the bleeding. And if it's really bad, they may need a bony decompression just to get some relief. Infection, again, this is something that's real. The most common is strep and staph, and we're seeing an increased incidence of MRSA. And the thing is, if left untreated, they can have permanent vision loss from orbital cellulitis. So this is a patient of mine. So some of these I've been showing other people's, but this is one of my patients who had 4-lid blepharoplasty. Post-op day 1 was doing great, no problems. On the 3rd post-op day, he called with pain and pressure. We had him come in, and he looked like this. It doesn't take an orbital surgeon to tell you that something's wrong. And this isn't just post-operative swelling. So he had orbital cellulitis with an orbital abscess. Had all these things of complaints: pain, eyelid swelling, erythema, decreased vision is what he reported, and decrease in extraocular motility. So we took him to the OR, we opened him up, we drained the abscess, had to leave a drain in, and he did fine. He's probably a little bit lower on that side than the other side, but ultimately he did fine. But hey, this is scary. The guy went in for cosmetic surgery, did fine, had no problems, and then ended up with a medical problem in the hospital on IV antibiotics and needed a large surgery. So complications of Ptosis surgery. So I guess the most common one is this one. This is a guy who 2 years after Ptosis surgery came to see me, and he has no vision in that eye, but he wasn't even able to wear his prosthetic because he's peaked. He's retracted. Whoever did his surgery probably left him a little bit too high. So we just did a retractor recession and released the levator, and now he's dropped and able to wear his prosthetic. This is one of my patients who had bilateral upper eyelid ptosis, good levator function, positive response to phenylephrine. So the whole room should know that I would do a muellerectomy, and I did. And then she came back to me like this, and this is always scary. So I took her to the operating room, and I assumed that she had a broken suture. And not only did she have a broken suture, it's gone. And so nothing was being held in place. There are some people who believe that you can just suture this back. But I think at this point for me, I don't really know what I'd be suturing. It's kind of blind. So I just converted and did an external levator advancement. And she had a decent result. Contour is not exactly the same, but acceptable in this case. This is a new patient. We just saw her last week, I think, and she's about a month out. And she came in at her 1 month post-op complaining of pain and irritation and foreign body sensation. She has SLK after MMCR. Never seen it. There have been reports of SLK associated with Blepharoplasty, but never with Ptosis surgery. So this is the first one. I'm not proud that it's me, but my cornea colleagues are taking care of her. And last I heard, she's beginning to feel a little bit better with aggressive lubrication and some steroid. This is a photo from one of my friends, Dr. Wendy Lee at Bascom Palmer. She reported a series of 3 patients, 3 or 4, I think, who had significant symblepharon and scarring leading to diplopia. All of these patients were on long-term glaucoma drops and had muellerectomy and developed significant scarring. So something to take into account when performing muellerectomy on patients who have glaucoma. This is one, so Botox is the #1 cosmetic procedure in the world. I actually think it's the #1 procedure performed in the world. And I was surprised to see that Allergan studies showed that about 5% of injections lead to ptosis. That's crazy. 5% of injections lead to ptosis. When they look at it closer to experienced injectors, it's a lot less. It's like 1%. So I've had a lot of patients come to my clinic. They got Botox and they came in. Now they're ptotic and they want to know what they can do about it. And there's fortunately not much. I typically encourage them to observe. And I've had people come in with every scenario that you could think of: their wedding, their cousin's wedding, their graduation. And we've been creative to find things that could help them. I don't necessarily recommend giving anybody phenylephrine, but for someone's wedding day, I think I did do that once. Nowadays, there's Upneek, which is just recently approved, FDA approved for ptosis. And I think that's a good option for those patients who have temporary ptosis secondary to Botox injection. The photo on the bottom was recently sent to me by a friend. This is after Botox injections, and you can see there's brow asymmetry, left-sided brow ptosis, and there's asymmetry of kind of like the folds and the wrinkles in the forehead. I would actually recommend more Botox here just to even things out. Filler complications, they can be mild, like this one, right? They're lumps and bumps that the patient doesn't want. The person on the left had this granuloma, had this actual mass of encased filler that we had to go in and surgically remove. The woman on the right had kind of this foreign body reaction from her filler that had to be removed. And then to get a little bit more, things that are a little bit more severe. This is a woman who had injections of filler in her cheek. Anyway, she presented a few days afterwards with this kind of slight erythema. And then there's this it was like elevated and warm at the cheek. And she actually had some numbness. She actually didn't have any pain. Rest of her exam was kind of normal. elevated white count, not really a temperature. And there you go. We got a CT scan and we found an abscess. So she had an abscess just entered the maxilla, and we had to take her to the operating room and drain her. And again, she did fine. Remember, she went in for filler, which just about anybody on Michigan Avenue nowadays is injecting filler. So now she had a real medical problem. And then to be even one step scarier, this was a case I got from one of my retina colleagues. This is a 48-year-old who had painless loss of vision in the right eye following a cosmetic procedure. Vision is NLP on the right. Rest of the exam I'll show you here, but basically lost vision immediately, didn't really know what they had done, had a central retinal artery occlusion from filler injection. That's scary. When my partner brought me this, the patient was already 1 day after their injection. I don't think there's really much you can do. Patient 4 day after injection, there's not much you can get back. So why does this happen, right? So it's intra-arterial injection of the product. And what happens is it's injected with force, and then it comes back forward through the central retinal artery, getting central retinal artery occlusion. So that's scary. It does happen, and everybody thinks, oh, I know where I'm injecting. I'm not injecting the right. Well, once you go deep, you don't really know where anybody's vessel is. So I read everyone the Riot Act. I tell every person that I inject that this can happen. I tell them, I think, I know where the anatomy is. I know where the vessels are supposed to be, but that doesn't mean that it can't happen to you. And it can happen from injections all over the face. So, it's important to understand the anatomy. I try to use a blunt cannula. It does hurt a little bit more, but it's less likely to end up being intraarterial. I use local anesthetic with a little epinephrine sometimes to help do constriction, if that helps. I pull back on the needle and make sure I'm not in a vessel, and I inject as slow as I can. I think even with all these things, the risk isn't zero, so it can happen. I think at the end of the day, it's important to let the patient know that, because that patient, she didn't know. And to be honest with you, she didn't know she was getting something called filler. She thought she was getting Botox, which may sound silly to us, but I think patients nowadays, they don't know what they're getting. They think everything's Botox. They think everything is without risk when it comes to these injectables, because you have all types of physicians giving it, and then you even have people who aren't physicians who are giving it. And so it's become so commonplace. I don't think people understand all the risk. So the take-home message is no surgeries without risk. So be prepared, be aware of the risk, know how to identify the complication, know how to correct the complication. And most importantly, I think these need to be discussed with the patient. They need to understand what can happen even when everything goes right on the operating room table. That is it. Thank you so much for having me. I've enjoyed this day immensely.
Excellent. Thanks, Pete. That was great. And it really shows that being prepared for complications and informing the patient really spans, of course, all subspecialties, and it's good advice for the residents and fellows for sure. I'd like to open it up for questions on either lecture now. We take just a couple minutes.
Regarding the reconstruction of post-cosmetic surgery, how do you typically handle that? Because these patients oftentimes require the amount of attention that a cosmetic patient would require, although they now have, true reconstructive needs. How do you go about approaching
that? This is tough. I mean, you are 100% right. They all take up as much time as anyone, because they quite often have sought out what they deemed as the best whatever lower lid bleph surgeon in the country, and have paid a large amount of money to have this done. Now they have a medical problem that you are just trying to make them safe. You're trying to get them to a point where they have an eyelid that can protect their eye and they don't have potentially blinding conditions. But they still have that cosmetic expectation, and that's hard. And I recently saw this patient that I mentioned earlier, and he kept saying, well, is it going to look good? Is it, like, am I going to get those bags? Like, how's this? And quite often they'll tell you, I refuse a skin graft. So what else you got? Yeah, that's tough. And I don't know. And not all the time. This guy's surgeon was super gracious. He's called multiple times, like he cares. Sometimes, you know, sometimes some surgeons will just wash their hands and they don't want to do anything with them. So I always try to stress to the patient, like, our goal is to get you to a place where you have eyelids that will protect your eye. I mean, I repeat that over and over again. And I stress it that this is now a reconstruction. Obviously, as a plastic surgeon, I want this to look as good as possible. I want the best cosmetic outcome that we can have. But our number one goal is to solve X. And typically that's to solve your lag ophthalmos, to solve your ectropion. I explained it in those terms. I want you to be able to close your eyes. I want you to be able to maintain moisture in your eyes, because if you don't, these things can happen. And I think most people understand that, but there's a lot of discussion.